Welcome to Chapter 4, Communications and Documentation. Therapeutic communication. This is defined as the principles of communicating with patients in a manner that achieves a positive relationship. In a nutshell, you want to be able to make sure that your patient views you as a positive person in that particular moment in time, and that they don't have any negative interactions with you. And this is going to take some adjustment of the communication strategies based on the age, the stage of development, and if there's any special needs or different cultures. You want to make sure that you practice strong interviewing techniques and learn how to diffuse any escalating verbal issues that you have with your patient, and any of the issues that may come about from family members or other loved ones while you're trying to conduct these interviews. Some patients are difficult, and we have to learn how to be able to deal with them and get them to communicate effectively with us as well, even in that stressful and difficult situation. EMS system communications. That's communications needed to call for additional resources, how to communicate the transfer of care of your patients to a provider of a higher license level, how to interact with the other people in your team as structured, the EMS communication system, which is our radios and documentation, communication with other healthcare professionals, and team communication and the dynamics that are involved in your ability to communicate. Documentation is recording the findings, treatments, and other things that go on with your patient while you're in direct contact with them. There's going to be some medical documentation and report writing. And then communication is a transmission of information from one person to another in varying means. That can be verbal or written. Effective communication is absolutely essential. It's an essential component in anything in life, especially pre-hospital care. And something that I'm going to touch on again is the use of exclusionary language, something that all professions tend to have an ability to do. EMS, or the medical field, not excluded from that. Our exclusionary language tends to be Latin terminology or medical jargon. A lot of people are uninitiated in this, and it makes it hard to communicate. So you have to pick your audience. You have to know when it's appropriate to use that exclusionary language and when it's not. Some of your patients are not going to have any concept of that language that you're using, and it may actually inhibit your ability to communicate with them because they feel offended or that you are making them feel like they are less than yourself. So make sure that you're thinking about it, but you have to know how to speak the language if you're talking to other people who are considered peers or superiors in your system. Good verbal communication skills enable you to gather information from the patient and the bystander, how to coordinate with other responders, and then how to transfer your patient. If you're really poor at being able to communicate with people, it's going to be really cumbersome for you to be able to get a good, solid picture of what's going on based on the patient, the bystanders, or any other clues that you can get, and then how you're going to transmit that information to somebody else who can further their treatment plan. Your documentation is written or electronic. Almost all documentation these days is electronic, and it becomes a permanent part of their medical record. That particular document is going to be filed away somewhere with them for their medical records for life. It never goes away. It's always going to be there. So make sure that it looks professional and it's thorough. Demonstrate that your care was appropriate and necessary, or as well as what was in the best interest of the patient. You want to make sure that you're helping others who are participating in the patient's care in the future or immediately in the best way possible by allowing them to understand what it is that you saw and why you chose the treatments that you chose. Complete your patient records. It guarantees the proper transfer of responsibility. So if you have a good complete report and it's turned in on time, the physician or other treating members can actually see what's going on and use that to help further the care. You want to comply with the requirements of the health department and law enforcement agencies, so that documentation should be done and completed in a thorough manner for any of the other agencies that are going to be involved or have a right to know something about that patient's care. And then for your organization, there are many of us that are going to work in a pay-for service, and we're unable to bill for something that we do not have complete and thorough documentation. Radios and telephone communications. This is really how we're linked to other EMS agencies, to other departments, or the members of your department and law enforcement. And primarily this is going to be based on your radio communications and how you speak to other agencies that you interact with. In some certain circumstances, you may be the only agency involved in that particular call and you don't have access to them. But you're still going to use your radio to call for additional resources or call for an additional agency to respond when needed in the event that you're on that call and something else has to happen. You have to be able to understand what your system can and cannot do, and that is the limitations of your radio network, when you can and cannot use cell networks, what's recorded and what's not recorded, and how you're going to use it efficiently and effectively. We don't want to tie up the air with nonsensical babble while we're on the radio because somebody else may need to use it, and we don't want to use cellular or mobile phones if it's not the appropriate way to record the documentation and conversations that are being had between different members in the system. So we're going to talk a little bit about therapeutic communication. That's verbal and nonverbal communication techniques and strategies that encourage your patients to express how they feel and achieve that positive relationship. Again, somebody called you for help and you want to come in and actually be helpful for that patient. You don't want to come in and automatically have a disconnect or some situation where the patient feels like they're at odds with you. There's really no real good thing that's going to come out of a patient who feels combative in nature with you. And while you can't prevent it all the time, you absolutely can start off most of your interaction with some kind of therapeutic communication strategy. So there's a few factors to consider when you're communicating. It's the age of your patient, making eye contact and your body language, your facial expression, the way that you're dressed, if it's appropriate and professional, the gender of your patient, the culture of that person or yourself, and your physical posture. That's going to tie back into your body language, your educational background, and the way that you speak to somebody, if it's using that exclusionary language or if you're using layperson language based on the appropriate audience, your voice tempo. We don't want to be militant and rapid. You want to talk in a smooth, calm, assuring voice. The environment that you're in, which is going to create differences in your posture, your body language, and the way that you're speaking to them, and obviously how loudly you're speaking to that patient. All right, so based on the picture here on the left, you can see how a message or communication is completed, and that is very simplistic in nature. So we have a sender who encodes the message, and then it needs to come over to the receiver, and then they're going to decode that. Now, things that get in the middle of it could be the noise, and that is miscommunication or some kind of distraction or inability to communicate effectively. And the end result is that when it's done being decoded by the receiver, you should get some kind of feedback that they understood what it is that you told them. So the Shannon-Weaver communication model is the sender takes a thought and then turns it into an encoded message. That message is sent to the receiver. The receiver then decodes it and then sends the feedback to the sender. And that's in a perfect system. We call that kind of like a closed loop communication, so that I give somebody a very simplistic message, they understand it, and then they make sure that I know that they understand what I said, or give me the communication that I need, which I will then decode as well. And this can become very cyclical in nature. Age, culture, and personal experience shape how a person communicates. Anecdotally, I grew up in the Midwest, and when I moved down here to New Mexico, I had to learn how to communicate differently because the culture that I was brought up in was very different in respect to how the New Mexico people communicate amongst each other. The way that I would speak, the pace and the volume and my use of body language is often perceived to be aggressive. And so I had to actually learn how to re-communicate just based on the way that most people communicate in this particular area. Body language and eye contact are greatly affected by culture. There are very specific cultures that find it offensive for you to make eye contact or lock eyes with somebody, and if your posture seems threatening and intimidating, you may put them on a rearward heel, and they're absolutely going to start to feel that negative impact about the way that you and the person that you're dealing with are communicating. Nonverbal communication is more often than not the more important thing that's happening when you're actually communicating with people. If you look aggressive, or you're speaking in a manner that appears to be aggressive or flat affect, it may come off as non-therapeutic, regardless of the words that you're using. Human beings use nonverbal communication keys to test sincerity or intent. So facial expressions, your body language, and eye contact are physical cues about what you're doing. If you're looking at the two pictures, you can see obviously the guy on top. He's smiling, he looks pretty jovial, so you would imagine that whatever he's talking about seems to be fairly innocent or happy. And then you look at the picture of the gentleman on the bottom, and right out of the gate you look at him and he looks like he's yelling at you. I mean, he may be just yelling something in general, but the facial expression that he has, or that kind of nonverbal cue, appears that it's forceful and aggressive. So physical factors that affect your communication are noise, anything that could really kind of obscure the meaning of the message, right? And that might be, again, your exclusionary language if that person does not understand the words or the vocabulary that you're using, or an actual environmental noise that makes them misinterpret what it is that you're saying, or keeps them from actually hearing the words that you're trying to get to them. Proxemics is the study of space and how distance between people affects communication. As a person gets closer, greater trust must be established. And this is going to come into cultural things and personal as well, for that personal space bubble. Some people are very open to being close to other people and don't mind being in close proximity. And then again, there are some people that if you're within several feet of them, they feel like their space is being violated, and they're going to become tense and very unable to communicate with you effectively, or provide you with the level of trust and comfort that you're going to need to be effective in your treatments. Okay, so asking questions is one of the most fundamental functions of the AEMT. Quite often, you have to think of yourself as a data processor. You're going to ask questions, and you're going to receive answers, and you're going to make decisions based on what was asked, what was understood, and then what was given back to you as an answer. Open-ended questions require some level of detail and response. You always want to try to shy away from certain questions, like anything that would just be answered with a yes or a no. You want to allow your patient to explain themselves in their own words. There are times and places for a yes-no question, but most of your close-end question can be really kind of detrimental to you getting an accurate and thorough history of what's happening today or happened previously. So some simple communication tools. Facilitation is you allowing your patient the ability to communicate. You're going to give them the time and the vocabulary needed so that they can present the problem to you. Silence is literally just allowing them to sit for a moment and kind of formulate that plan, and you're not pressuring them. They don't have to answer immediately. If they just want to sit and kind of think about what it is that they want to tell you, allow them the space and the time to be silent. And then reflection is you asking that question, or them asking you a question or making a statement, and you reiterating it in a manner that shows that you actually understood what was said, or that they would agree with what you said. Speaking with empathy is just being compassionate. You want to make sure that you're allowing them to know that you empathize with what they actually have to say. It's really part of that therapy so that they believe that you care. And clarification is a pretty obvious point. If you don't understand something, you got to make sure that you can get it clarified. And again, this is going to come back to that language and how you use it. So sometimes things need to be simplified, or they may have to actually be expanded upon based on the level of trust and communication abilities between you and your patient. There will be time for some confrontation, and that means that we're actually going to come head on with the problem instead of avoiding what is actually happening. And then we have to make sure that we have the correct interpretation. So again, make sure you communicate and clarify, and then you can express that you understand what's going on, and then explain and summarize what the conversation was. When you're interviewing a patient, consider using some touch to show compassion and caring, but make sure that you're using that with the right type of patient, right? We have to always consider what somebody feels like or how they're going to take that touch. Some people have plenty of ability to allow others who may be complete strangers within close proximity and feel comfort with being touched. Other people who come from a different culture may find that to be offensive. So make sure that you use it sparingly and you're going to use it professionally, right? We're not getting really handsy with people, but it's just a simple gesture to let somebody know that you actually care. Some of the things that you want to avoid when you're actually interviewing people is giving people false assurances, right? You don't want to tell somebody everything's going to be fine. That's not something that you can actually guarantee, so you want to make sure you don't want to tell people that kind of stuff. You don't want to give people unsolicited advice. There's a teachable moment, but if your opinion differs from theirs, that teachable moment may be something different. So make sure that you kind of use due regard with that when you're coming at somebody with a teachable moment. Don't give them something that they're not asking for, because they're going to find that offensive. You definitely don't want to use leading questions, right? You don't want to get the patient to where they feel like they only have one way to answer, and that's because you are giving them the one path. And then you don't want to interrupt them when they're trying to speak. A lot of communication is lost when we have the inability to allow other people to speak. And so when somebody is doing the talking, you should do some active listening and only interrupt when it's absolutely necessary. Don't use questions about why, because then now you're insinuating that their moral integrity is less than your own. So make sure that you allow them the ability to communicate the reasons behind the things that happened or may need to happen are of their own. And then again, speaking in that professional jargon, right? There are some patients who can benefit from you speaking in that language, and you're really going to be left up to that best guess scenario on that based on what your patient presents and their ability to communicate to you. We just want to make sure that we're always testing the audience. We want to know what that audience is, and we want to know what it is that we want to try to do in regards to communicating with them. Speak to their level so that they would be more likely to speak back to you. So this slide says friends, family, and bystanders. They may be valuable, but we always want to make sure that your patient is the one who's answering your questions if they're able to. Sometimes they may not want to actually answer your questions, and they may defer, but never outwardly start with somebody else answering questions for your patient unless they're incapable. If they decide to have the family and friends nearby, it might make them less anxious, but you're still going to give them the first shot to describe what's going on or explain to you what it is that your interaction is intended for at that particular moment. A couple of golden rules to make sure you have a good interaction, and this is to help calm and reassure your patient. Make and keep eye contact as much as permissible, especially considering that person's cultural differences. You want to make sure that you establish a rapport, and that's just like showing somebody that you have good intentions and you're empathizing with them and you want to do the right thing for them. So try to get them to open up and trust you, and then tell them the truth, especially if you don't know something. If you don't know the answer to a question, never lie to your patient. Make sure that they know that you're going to do everything that you can and that you'll get the proper answers for them. This rule applies to anything in life when we're communicating. You actually have to make sure that you're aware of your body language. If you're being imposing or you appear to be closed off, patients are going to tend to not want to tell you the things that you want the answers to. So be mindful of the way that you present yourself when you're actually making the gestures or you're attempting to make communication, because again, nonverbal cues are going to come in and override anything that's said. You want to make sure that you speak slowly, clearly, and distinctly. Some of us tend to ramble with the words. I myself, even while I'm trying to do some of these video lectures, because I don't have it rehearsed, have stall words or different utterances that maybe give me a little extra time. And you want to make sure that you don't start to just kind of ramble on and get people caught up in just a bunch of words that you're using just to have said them. So make sure that you're calm and that you're confident. Something that we always try to tell EMTs is that if you appear to be stoic and very calm, other people that are around you are going to be much more likely to follow what is that you need to have done. If you appear to be out of control and you're not confident in your decisions, people will begin to second guess you. So relying on the fact that you are trained and you have a plethora of knowledge and you can deal with most situations is going to be ultimately something that creates success in the future. Difficult patients come. They're not always, or they're not always consistently difficult, but there are times that you're going to deal with people who are just having a bad day, and it doesn't matter how you present yourself, you're going to be part of their bad day. And so you want to make sure that you stay calm. If you allow somebody to get you agitated, they're going to actually control the situation, which is not what you want to have happen, especially with somebody who's being difficult. So stay calm, be open, be honest. Don't try to deceive them. A lot of people are very quick to pick up on deception. And then make sure that you're considering your scene safety. If you refer back to one of the previous videos about scene safety, I said before, make sure that you never put yourself in a situation with somebody who is agitated or unpredictable, and don't allow them to get between you and a doorway. You always want to have some kind of egress, and you want to make sure that your situation isn't going to become volatile. Never, ever, ever threaten your patient, because at that point they are unpredictable because they do not have any concept of what it is that you're trying to do. If they think that you are going to impose some kind of harm on them, they're going to become violent and unpredictable, and it's a no-win situation for everybody involved. If you look at the table 4.6 and read for yourself, you can see that there are some very specific ways that you can interview an older adult patient, and this applies to just about anybody. You want to make sure that you're being compassionate and very polite when you're dealing with somebody. Again, remember that they called you for help and not necessarily to feel like they're a burden. So children present with their own set of unique circumstances. They're usually frightened. They tend to be afraid of strangers because that's their developmental psychology. They're in that particular life stage where they're not sure of who they can and cannot trust, and they tend to panic if they're separated from a parent or a loved one that they do trust. Make sure that you allow the parents to stay within proximity of the child to reassure them. Use lots of eye contact, come at them in a slow approach manner, smile, and be very subdued in the way that you speak to them. They're not going to be able to articulate vocabulary like you can, so especially using any kind of technical jargon is really not going to work for them. You need to make sure that you're being honest with them and just comfort them as you're going through the processes. If you can, make sure you put yourself down at a lower level. You don't want to come in as the impending doom because you're towering above them and looking down on them. Right? That makes most people, adult or child, feel threatened. So we always want to make sure that we let that person know that we're there to help them and not cause them harm. If you can, make sure you're always involving a parent in the child's care, and then try to demonstrate on somebody else who is not scared or injured what you're about to do with them. You don't obviously want to start IVs on mom or dad because you're about to start one on child patient, but show them the general motion that you're going to go through, and be honest with them. Tell them that they'll feel a little pinch. Right? We don't want to lie to them because it's going to create distrust. And if you can distract them with something, use a toy. As a side note, blown up gloves tend to be those things that people like to make into toys, but it's generally inappropriate, and we don't want to give toddlers or anything like that something that's a choking hazard. So it's usually best to give them something like a small stuffed animal or something like that that you may keep in the rig just for that particular set of situations. So again, be honest. Don't tell somebody, especially a child, that something's not going to hurt or that they're not going to feel anything, when in fact they probably will, because you're going to break that bond and you're going to dissolve trust. And it's really hard to regain after they believe that you're deceiving them. And children are going to be very modest. They're shy. That's a natural instinct for them. And so you want to make sure that you're keeping them covered and that you're keeping them feeling safe and secure. Make sure that you're explaining to them what you're doing and why you're going to do that. And that's informed consent, regardless of child or adult. Okay, so this next section is on communicating with hearing impaired patients. For all intents and purposes, this should be a no-brainer. Just because somebody's hearing impaired does not mean that they're not intelligent, and they're not embarrassed by the fact that they have a disability with hearing. Make sure that they can actually see your lips. They've probably spent a good long portion of their life reading lips to understand what it is that you're saying because they can't hear it. And most are going to assume that you don't know sign language. If they have some kind of hearing aid or device, make sure that they have it and that it's functioning properly. And if they need it, go and retrieve it before you leave with them. Ask family members if they have other means of communication, if that's just specifically by writing, or if they only sign language, or if they communicate with some other device, or they can type and use a voice generator. Again, this is just kind of really touching on, if you have a pen and paper, often people with hearing disabilities can effectively write for you and tell you what it is that they need through the written word. If they can read lips, they can usually tell you what it is that they need to know. If they can read lips, you want to make sure that you're speaking slowly and use very distinct facial patterns. Never shout at them. If they're hearing impaired, shouting doesn't make it any better. It's just going to come off as rude. Listen carefully. Ask short, simple questions that they can give you short answers to. So this is some basic gestures in sign language as far as how to communicate some simplistic ideas. While it's kind of outside of the scope of what we're teaching, sign language does have some very simple ways to communicate in regards to emergency medicine. So on this particular slide, we're looking at patients with visual impairments. You want to make sure that if the patient is visually impaired, you want to know, do they have any vision? Can they see light sources? Can they actually see shapes and colors? And then expect that they also are normally intelligent, that there's not a mental capacity that is also associated with them being blind. And then make sure that you're telling your patient in a very consistent, calm manner what it is that you're about to do. Again, there's a level of trust that needs to be maintained with somebody who is allowing you within such close proximity to them when they do not have visual capabilities. So if it's culturally acceptable or the patient accepts it, you want to say, if it's culturally acceptable or the patient accepts it, you want to stay in physical contact with your patient as you begin your care. Make sure that they know that you're close or right next to them. If they're able to walk and ambulate to gurneys or ambulances, assist them. Put your arm out, let them hold against you, and then if they have some kind of mobility aid, like a cane or any of the other devices that come with that, make sure that you retrieve that so that they have something that's normal for them when they're going to be personally mobile without any assistance. So in this particular slide, we're looking at guide dogs. They are identified with a special harness. If it's possible and not an issue, which most hospitals should be able to accept a guide dog for a visually impaired patient, transport the dog. There's a very small amount of risk about transporting the animal in the unit without having them secured. Most rigs do not have animal seat belts, so to speak, in the back, but we're going to take a gentle, smooth, calm ride. If you're unable to transport the dog, make sure that you arrange for somebody else to transport the dog, or find somebody that can care for the dog in the absence of the owner. You want to make sure that that animal has full care and is safe when you depart your seat. Communicating with patients who do not speak English. If your patient speaks some English, you should ask, and then make sure that you're going to use short and simple questions with simple English, and don't use colloquial sayings. You don't want to confuse a non-native speaker with communication that's not easily interpreted sentence patterns. Make sure that you're pointing to parts of the body that you're talking about, and if there's anybody that can actually interpret for you, make sure that you use that. Consider using some common phrases in another language used in your area. So if you know a little bit of Spanish and you can actually use them appropriately in this particular area, it's probably going to go very well. Communicating with special needs patients. You never want to overlook the needs of people with speech or communications disorders. Touch and eye contact are helpful bridging mechanisms, so make sure that, again, if it's culturally acceptable or that patient's willing to look you in the eyes or allows you to touch them, use that in a therapeutic manner to try to gain trust. And then utilize the family members or the caregivers that can actually help facilitate your efforts, right? If you have a sibling or another family member who is able to help you establish that bond and secure some trust, allow them into the treatment picture. In regards to communicating with other healthcare professionals, you want to make sure that you're verbally communicating with the hospital staff who has at least your level of training, if not more. And again, this is where we're going to get into that exclusionary language. There are times, especially when you're making sure that you're communicating with other healthcare professionals, that you're going to use technical jargon because it leads a little credibility to your treatment and that you're professional. You don't want to insinuate that you do not have a sophistication level that warrants your treatments. Your oral report should be a brief synopsis of what your written report was going to look like. You're going to give them the name, the chief complaint, or the injury or illness. You want to give them some detailed information in regards to what it is that you found and how you treated it. You want to give them any really important history, like if they have allergies or specific medications that can affect the treatments. You want to make sure that you let them know that you found pertinent findings in the physical exam and how that patient responded to your treatment. Always give a set of vital signs, if not a complete set of trending vital signs if you've got multiple sets, because it's going to allow the next person to understand what treatment is or is not working. Communication systems and equipment. Most EMS communication systems today are based on radios. Ours is no different. You want to make sure that you know how to use the equipment and how to communicate effectively while you're transmitting on that equipment. Radio operations are regulated by the FCC, and so there are very specific procedures that you have to follow when you're communicating amongst interagencies or within your own agency. There's two-way radios, and that is a transmitter and receiver, and then we get into channels, which are frequencies or a specific frequency that's used to carry voice and data communications. The frequency is based on the number of cycles per second in a radio signal. Base stations are any radio hardware containing a transmitter and a receiver in a fixed place, i.e. not a EMS related vehicle. That would be anything such as a hospital or other area that is in a fixed location. This includes dispatch centers, fire stations, ambulance bases, and hospitals. So base stations are any radio hardware containing a transmitter and a receiver in a fixed place. This is places such as dispatch centers, fire stations, ambulance bases, or hospitals. There are other facilities throughout the state that also have that capability. They tend to have more power and a higher, more efficient antenna system than a mobile or a portable radio. Your handheld radio has the shortest range and the lowest amount of power, with a mobile unit affixed to, say, an ambulance or a fire truck or law enforcement vehicle having a little bit more power. But the most powerful ones that have the greatest reach are going to be in your base stations. So again, your mobile radios are mounted inside a vehicle. They're used to communicate with dispatch and other public safety agencies based on their radio channels. Medical control, they have lower power than that base station, and they're assigned to a specific frequency, although most of them have the ability to change frequency. Frequency bands are the portions of frequency spectrum assigned for specific uses. Most common for medical communications is the VHF and the UHF. Now we're also on 800 and some are on 700 megahertz. Portable radios are the ones that I was speaking of earlier, where you have a handheld two-way radio. It's got a very limited range. You can usually speak to your vehicle, which then repeats to a base station. If you have a base station that's fairly close and has pretty good line of sight, your portable radio may communicate directly with them. So a couple of different radio systems are simplex, the push-to-talk, release-to-listen. That's typically almost all radios. Duplex can do simultaneous transmission and reception. You don't see that in the EMS very often. And then multiplex, which combines analog and digital signals. It can transmit two or more different types of information. That's voice and telemetry, and not typical in your simple radio systems in EMS. Repeaters are special base stations that receive a message and then amplify it and send it to another location. Digital radios and trunk systems. Digital radio systems allow the transmission of digital signals, which is the computer, or analog, which is voice. They're clearer, they allow more transmission of a greater volume of data in the same bandwidth, and they can communicate with digital and analog radios. With digital trunk radios, many frequencies are assigned to a group. This is talk channels or talk groups. Signals from base and repeater stations are generally heard and understood from a greater distance than a signal from a mobile unit. We've already kind of discussed that, your handheld being the least powerful, the mobile unit being the next most, and then going to a base or a repeater. The success of communication depends on the efficiency of your equipment, and that's also based on lines of sight, geographical issues, and whether or not there are a multitude of transmitters or antenna. The maintenance of radio equipment, you should always have it checked and serviced at least once a year. updated for its programming. Make sure that anything that's outdated or broken is removed from service because it's now a liability. Do not subject your equipment to dusty, damp, or wet environments. It's electronic and it really generally doesn't like to be dirty or wet. Cell and satellite telephones. In some systems, it's often okay to use cellular phones to communicate. Quite often, we'll make the conversation with an MSEP via cellular or mobile phone. You can also use satellite phones in certain areas. I know in our specific area, especially with our specific fire department, Bernalillo County has a satellite phone that is used in certain districts because of the lack of any and all communication ability in the East Mountains on the south side of the county. So it is available. We tend not to use it unless it's absolutely necessary because it is still a very expensive mode of communication. So digital equipment, things such as telemetry, capability of measuring vital life signs and transmitting that data to a distant terminal. We utilize that in our cardiac monitoring, and you'll see that there are a lot of telemetry options in the field with current technology. This is going to be sent either by Bluetooth or by cellular capability to whatever receiving device is required. Okay. Interoperability allows agencies involved to share information with each other in real time. It connects landlines, cell phones, and computers, and you're going to see that in dispatch with radio communications and the ability to send data through the World Wide Web. SafeCom communications program was developed by the Department of Homeland Security. It has a set of national interoperability standards to develop compatibility and across communication systems. And that's basically stating that like agencies will have the similar radio frequencies or the ability to connect to one another so that we can communicate. Association of Public Safety Communications Officials has radio hardware standards, Project P25. Ensures that digital radio equipment manufacturers develop systems that are compatible with each other and older systems in use. And that's backwards compatibility, so that on the new, latest, and greatest radio systems, we're able to talk to smaller departments or agencies that can't afford the most current technological advancements. So based on those standards, we're still able to communicate in some form or fashion. So CADS, this is computer-aided dispatch. This is a computerized method of call handling. Data for dispatch can be sent directly to the EMS unit by data transfer. We call that MDTs in our particular service, and that means that the dispatch center is able to take the information and encode it electronically, send it wirelessly to a mobile data terminal, and we're able to get all of their information without having it to come through radio communications. It can recommend emergency actions for patients or bystanders. This is the MDT I was just speaking about, mobile computer terminal inside an ambulance or other response vehicle that receives that data from the dispatch center. Can give you the address and directions and allow for communication without the use of the radio. Because radio airtime is so precious, the mobile data terminals and computer-aided dispatch is pretty much used exclusively, especially in our area. Backup communication strategies. There's always a backup plan with communication, so that means that your dispatcher is able to contact you when normal procedures don't work. That might be a landline backup, or the cellular service backup, or actually just going to a different type of radio in the event that your particular radio isn't working in the area that you're at. This slide is about notification. This is typically how the 911 system works. Someone tells EMS that an emergency exists. The dispatcher determines the relative importance of the 911 call. And again, dispatch generally is the gatekeeper that figures out what the emergency is of the person that's calling, whether or not that's law enforcement, fire, or EMS related component. Based on MPDS coding and ProQA, they're going to assign the appropriate units and the response plan, and they're going to provide key information to those units so that they can be prepared for whatever it is that the emergency is. So dispatch communicates with the EMS team from that particular headquarters. Most dispatch in government agencies are separate from office complexes. The appropriate crew is contacted and informed of the call, and then you will inform the dispatcher when you arrive and have made patient contact. A lot of these things are done again through the electronic MDT, and we're not using the radio for that anymore. So en route communications. Once the responding unit is underway, the dispatcher may ask the caller for additional information and then may give that caller pre-arrival instructions so that in the event that something needs to happen prior to the arrival of the responding units, that treatment is begun. Communications during your transport, and that's communicating with the receiving hospital. This is still done primarily through the radio, and we're giving a radio report to the receiving facility so that they are aware of the patient that is incoming, their current chief complaint, treatments and vital signs, and an estimated time of arrival. Some services will transmit their patient care report to the emergency department. Most will transmit that after the call is completed. There's usually a general timeline that it has to be done so that the patient records are all in one area. Communication with medical control and hospitals. Again, this is mostly done by radio. In the particular case of communicating with medical control, that can be done via radio, but quite often in today's technology, it's done via cell phone. It is still all recorded. So in regards to communicating with your hospital or medical control, you want to make sure that you kind of approach this with a plan and organize. You want to make sure that right out of the gate, you're letting the person know who it is that you're communicating with, what it is that you're trying to communicate to them, and then give them the basic information and allow them the ability to ask you for follow-up questions if so needed. What we don't want to do is get long-winded and just start talking and giving a bunch of extra information that's going to just complicate the radio communication. This next slide is communicating again with your medical control or the hospitals, and the big important message on this is that you want to plan and organize your radio communication before you hit that transmit button. It's really, really hard for the people who are receiving or helping you make decisions if you are giving them lots of extra information that's not really pertinent to the call. So make sure that you're concise and very calm and confident in what it is that you're trying to communicate. You want to be objective, accurate, and professional, and follow the standard format by the local EMS system. People with scanners can be listening. As technology grows, even if you have something that's scrambled, there are people that have the technology to unscramble. So we never want to give any specific identifying information over the radio, such as the patient's name or anything else that could violate HIPAA. So depending on how your protocols are written, you might need to call for MSEP for permission before you can administer medications, to determine the transport destination, or stop treatment or decide not to transport a patient. In our very local protocol, there are specific protocols that or guidelines that require an MSEP consult for all manner of treatments by all license levels, and there are some that are just standing orders. So make sure that you know the difference between what you can do without talking to an MSEP and what you actually absolutely have to have an MSEP for. Most MSEPs, or your medical control physicians, are going to base their decisions or their instructions on the information that you give them. You never want to use codes or weird jargon. Make sure that you're speaking in an open, plain English, plain text format, and give them something that's really accurate and concise. Once you receive the order, make sure that you repeat it back so that that physician understands that you know exactly what they're giving you for an order and that you're not going to violate from what it is that they give you. Also make sure that you're not going to blindly follow an order that doesn't make any sense. If a physician gives you an order for a particular drug that's outside of your scope, make sure that you follow that back up and let that physician know that that's not within your scope or not within your treatment capabilities. You never want to do something just based on what somebody said, because there's quite often a problem with your communication. Something got lost in the way. If you think back a little earlier about the transmission and encoding and decoding, if there's some kind of interference there, that's what happened. Special situations. We want to make sure that we advise hospitals of special situations like hazmats or highly contagious situations. A few years ago, the Ebola scare was out, and we had to come up with certain plans so that we could have very specific decontamination rituals when we got to a hospital with a patient that we believed to have that particular virus. The same is going to be included in any kind of a hazmat situation where we need to actually decon the patient and the providers, and that if there's any kind of a rescue in progress, right? If you're with a patient and you're transporting and they suddenly suffer cardiac arrest, we want to make sure that we update the hospital early and let them know that CPR is in progress, or that we are letting people know that there's a multiple casualty incident, right? So if we have an MCI, we can very easily overwhelm the hospital or hospitals based on the protocols or the plan for that particular situation. You have to make sure that you get this done early and make sure that everybody that's a player in the system understands what's happening, and then identify special needs that you might have, whether that be hazmat of the patient or a particular type of procedure or facility. Effective radio communications is really just about using your system effectively. Use a standard radio operating procedure, which reduces the amount of misunderstandings. It keeps your transmissions brief, and then you develop effective radio discipline. You're going to always follow your local protocols because they're going to dictate when and when you should not use a radio and what should not be allowed over the air. Written communication is your patient care report. It's a legal document. It records all the care from dispatch to the hospital arrival. There are two different types, and that's written or electronic. In today's day, it's almost always all electronic. And again, we want to make sure that it's accurate and thorough. And if there are errors, those are also included in the report. The adage is if you didn't write it down or you didn't record it, it never happened. That can ultimately work negatively against you if you purposely omit something in your report. So make sure that it's accurate regardless of how you feel it's going to make your treatment look. In EMS and medical professionals in general are going to use military time in determining the time frame of when we made patient contact, any of the care that was given all the way up to termination. Make sure that you have a basic fundamental skill of writing effectively and accurately, and make sure it's complete, accurate, and legible. Just because you wrote it, if nobody else can read it, it's going to make it really look poorly on your ability to explain how you treated somebody, or it could cause a miscommunication in the treatment algorithm that happened, potentially jeopardizing your patient. Legal issues of the patient care report. You can't write anything that has bias or personal opinions. Right? Again, as a professional, we're utilizing the idea that we are writing objective findings in our report. The only thing that's subjective is what your patient says in history of present illness or past medical history. Your report needs to be complete, it has to be well written, it has to be legible, it has to be professional. Remember, even if it's an error, you cannot omit it because it's going to negatively impact you if it sees daylight. Use proper spelling, proper grammar, and accurate terminology in your report. This leads credence to the fact that you again are a trained professional and that you are capable of delivering the care that you have delivered. Okay, so your patient care report serves 6 different functions. It is part of the continuity of care, and that means that your document is what typically started care and then is going to show as the beginning of treatment as it progresses into the definitive treatment. It can be used for legal documentation. It can be used for education as people will go back and review it and see if they can obtain any knowledge of a particular disease or injury process and what did and did not work. Administration or administrative information, and that's for the agency that you work for. And then there's essential research records, right? And so that is any and all patient care reports are actually filed with the state, and they are used for determining different types of information in evidence-based medicine. There's also the immediate evaluation for CQI or QA, which should also always be looked at as an education strategy to further bolster a AEMT or EMT in general's clinical capabilities. So here's some more components of a PCR. And you want to make sure that you document any changes in a patient's condition, and then there are some specific pieces of information collected in your PCR, not necessarily in this order, but some of them are the chief complaint, the level of consciousness or the mental status of your patient, some vital signs, assessment findings, and the patient demographics. In the narrative, there are some things that are included, such as the time of the events, the assessment findings, emergency medical care provided, changes in the patient after treatment, refusal of care, the staff who continued care, and significant negative findings and important observations about the scene. Reporting errors, again, we've said this 2 or 3 times. You want to make sure that if you leave something out or record it incorrectly, do not try to cover it up. Falsification causes poor patient care and possible suspension or legal action. If you willfully omit an error, it may be seen as negligence or criminal negligence, and you never want to put yourself in that position. Make sure that you have accountability for everything that you've done. Record it, whether or not you feel like it is going to impact you negatively. There are some minimum requirements in your documentation of the PCR. Ensure that all your procedures performed are documented. That includes anything that was successful or unsuccessful, insurance codes obtained, and the appropriate medical necessity signature obtained if so required. Your patient care report should indicate why a patient may have needed emergency care. Okay, refusal of care. This is really a common source of lawsuits nationwide, so you want to make sure that you document any assessment findings and any treatments or medical care that you gave. Make sure that you articulate that your patient had decision-making capabilities and have them sign the refusal form that states that they understand the risks of refusal. If there's a witness, you want to make sure that you can get a witness to actually sign as well, so that it leads credibility to the fact that your patient willfully signed that refusal. Then make sure that you complete your patient care report. A little bit of a follow-up on special reporting situations, and this is based on the local or state requirements. These include gunshot wounds, dog bites, some infectious diseases, suspected physical or sexual abuse, the use of mutual aid services, and a mass casualty incident. Your local area will determine that for you, and you should know that based on your employer. The patient care report and all the information in it are considered confidential documents. Remember HIPAA. You may not have time to complete the full PCR while you're at the hospital, so you can have a paper drop-off report or a transfer report, but there are usually specific guidelines on when your patient care report needs to be completed and transmitted to the receiving facility.